Right. Okay. I'm going to present a case, and it will be an interactive, actually, a case discussion. So we might need to stop at after some slides to discuss the findings. Sorry, it just came in the first. Just going to the next case. Right. Okay. So this case about a 94 years old lady. She was normally independent. She had a background of hypertension and osteoarthritis. As we can see here, she was on some antihypertensive medication, including lercanidipine and bendroflumethiazide and doxazosin. She lives alone, and she's not a smoker, and she drinks alcohol rarely. She came into the hospital with 1-day history of worsening exertion and shortness of breath and mild epigastric pain, which was on and off for about 1 day. She had no palpitations and denied any dizziness or syncope. She didn't have any symptoms of orthopnea or paroxysmal nocturnal dyspnea. She also denied any cough or fever. This is her examination, or first her vital signs. She was afebrile. Her heart rate was 130 to 140. And it was irregular blood pressure was, she was hemodynamic and stable. Blood pressure was 108 over 70. Actually, I cannot see the, yes. So the blood pressure was 108 over 76. She was, her saturation was 95% on room air, and respiratory rate was around 18. She was using about 4. Heart sounds were normal with variable intensity, and there was no audible murmur. There was a raised JVP and few basal crackles in both lungs. She had leg pitting edema, that was up to the knee, but it was like mild and not really massive pitting edema. Her abdomen was soft, non-tender, and her weight was about 59 kg. So she had this ECG. Can you see the ECG? Well, okay. So I'm going to stop here for a comment from the panel members. Would you like to comment? I think they.
So I mean, this is a 12-lead ECG. Now, without having a ruler, it actually looks fairly regular, I would say, quite interestingly. There may be some subtle variation in the RR rate. The average heart rate, probably you're looking around 150 beats per minute. So it could be suggestive of flutter. However, if you look in V1, where you normally see the nice flutter flutter waves, you can't really see evidence of the flutter waves in V1. So again, could be atrial fibrillation or atrial tachycardia. There are some interesting complexes where they're predominantly narrow. You see Q waves in V1 to V2. There's also suggestion of potentially Q waves in the inferior leads in leads 3 in AVF. There is evidence of left axis deviation. And interestingly, you can see that there are some narrow complexes and then there are some broader complexes within it, very interestingly. Whether that could represent intermittent sort of aberration is a potential. Although, again, this complex, I don't know, can you see my arrow? Or probably can't see my arrow. If you look on V3, so the first, second, third, fourth beat, you can see that is slightly broader than the third one. But if you look at V1 to V2, it's not really typical of a right or a left bundle branch block. Whereas if you look at V6, the first beat on V6, and the fourth beat on V6. Again, they're broader, and on V6 that could suggest the right bundle, but certainly we're not seeing that on V1. So I think this is a narrow complex tachycardia with some evidence of broader complexes within it. It looks fairly regular, so an atrial tachycardia would be sort of my interpretation, or it could be an atrial fibrillation as well. Yeah.
Right, Dr. Junaid, do you have any further comments?
Thank you. Yeah, I think I broadly agree with what Ahmed is saying. I think there is some intraventricular conduction delay. As you can see, even in the narrow complexes, there is a notched QRS complex and V5 and V6 within the narrow complexes. And I think I agree. I mean, I've historically learned and taught people to say that if you have a heartbeat of 150 and it is regular and the patient is sitting talking to you, you must consider atrial flutter until proven otherwise in this situation. So for my money, I think the diagnosis probably rests between either atrial flutter with intermittent broadening of the QRS complex with aberration. I don't think this looks like a supraventricular tachycardia as we know it as in a reentrant supraventricular tachycardia. It doesn't look like an accessory pathway accelerated type tachycardia. Could it be atrial fibrillation? I would wait and see. I would probably want to look at it in with an increased paper speed to understand what the baseline opens up to. And then we could potentially identify either formed P waves or complete chaos. So I think there are things you could do with the ECG acquisition to get a better picture.
Okay, right. Yeah, yes, I agree. Of course, you covered all the possibilities or the possible diagnoses.
I just wanted to add one thing. Can we just go back a second? So one thing just to add. So the interesting thing about sort of aberration, we usually see aberration where the heart rate increases, the ventricular rate increases. So actually what we're seeing here, we're not seeing a distinct speeding or variation in the heart rate to cause aberrancy, which again is quite interesting. But yeah, sorry, that's just the thing I wanted to mention. You can carry on.
Right. So this is the chest X-ray of this patient. And again, anyone would like to comment?
Yeah, well, I'll take that if you don't mind.
Yes,
so really an elderly individual who has a background of hypertension and then presents with this tachyarrhythmia, and the X-ray probably shows what we would expect clinically to be the situation. She's got bibasal crackles on the examination and a tachyarrhythmia. The X-ray confirms the presence of pulmonary congestion. The pattern basically is fitting bilateral in sort of pulmonary congestion. The hyla are prominent, and you wonder whether this is long-standing hypertensive type heart disease or whether there is something else going on which might make both the hyla more prominent. Although there is no splaying of the trachea and tracheal bifurcation, so there doesn't seem to be a suggestion that there is massive atrial enlargement, but that is it. Looking at it from the bottom of the lungs, both angles are obliterated. There is a greater suggestion of possibly right-sided effusion than in the left side. The left side is slightly less impressive, but clearly the angle isn't as sharp and there is some fluid there. And that's it. I think the rest of the soft tissue shadow and the bony skeleton seems to be all right.
Yeah. Yes. Yes, Professor Junaid, I think you covered everything. Anyone would like to add any comment? Otherwise, I will go for the next slide. So these are the blood tests for this patient. So as we can see here, she has a normal white cell count, but neutrophils slightly raised. Lymphocytes is, as everyone now has a low lymphocyte with this COVID era, even negative ones actually. So we see a lot of this pattern actually nowadays. CRP is elevated, and urea electrolytes almost there's nothing significant. Calcium, magnesium were within normal. limit heart troponin, three-rate troponin, as we can see, the first one was 26 and it went up to 38, which is not really massively increased and could be attributed to the arrhythmia. Liver function, the only abnormality was the slightly raised ALT. And she had a procalcitonin, which was not really suggestive of infection. So the diagnosis at this stage was first documented atrial fibrillation with rapid ventricular rate and decompensated heart failure. To rule out ACS, as we can see, we had the serial troponin, which were really not massively raised, and the patient did not have chest pain as such, though she complained of abdominal pain. The COVID-19 was negative. So how this patient was managed? So she was admitted to CCU. She was put on telemetry. She was started on bisoprolol orally, and digoxin was added as well as part of the management to control the heart rate. Her CHA2DS was quite high, and she was qualified to have anticoagulation or anticoagulant, and she was offered Apixaban. She was started on IV furosemide, and following the control of heart rate, she had a transthoracic echocardiogram. This is the ECG following the heart rate control with bisoprolol and digoxin. And I would give an opportunity for the panel to comment on this ECG.
Ahmed, over to you.
Okay, so again, it's a 12-lead ECG. So if we look at the ventricular rate is certainly slower than the original ECG. I think there's a bit more convincing evidence of atrial fibrillation on this ECG. You can't really see any clear organized atrial activity, any clear P waves. You can see that there's a variable R interval here, and then we're seeing these sort of complexes which are fairly premature, which would give the suggestion of potentially of a premature ventricular complex. But you can, I would say that this is certainly more suggestive of atrial fibrillation. If you look at V1, you've got this coarse fibrillatory waves. Now, actually, interestingly, these ectopics, they appear to be. You can see that there's a long and then a short coupling interval. So actually, these would be representative of Ashman phenomenon, which actually sometimes can look like right bundle branch block. So I think you got them there. Yes, yeah.
So this is Ashman phenomenon.
So I think you're right there. So Ashman phenomenon, you see this long interval, R interval. So it's in a patient who has atrial fibrillation, where they have a long interval, and then they get this complex, which is actually aberration rather than a premature ventricular complex. I think that's what often when you see it on the ECG, it looks like a PVC, but as you can probably see, it's not that broad, and it actually represents aberration of a right bundle branch morphology. So yeah, absolutely.
I think
thank you very much. Professor Junaid, do you want to add anything?
I was just going to make a comment. I mean, I thank you. You've put a name to something that I've always, I've not necessarily known the name of, but we've always questioned the appearances, because you're absolutely right. I think the appearance in V5 and V6, and the way I was looking at it in a slightly roundabout way, is the fact that the presence of an S wave in V5 and V6, however narrow it is, does suggest to me of a right bundle branch type presentation if it's seen in the left-sided leads. And I've always questioned the location of these beats coming. It's certainly not broad enough to be ventricular. Then you wonder whether it is higher up or perhaps just after the bifurcation of the bundle of his, somewhere very close to that, which then gives you a very odd way or the current traverses. So yeah, so Ashman phenomenon it is. I learned a new thing today. Thank you, Ahmed.
Okay, right. So we go to the next slide. This is another ECG. As we can see, maybe it's more clear here in this ECG that it's an atrial fibrillation. Do you want to add anything?
Yeah, I
Ahmed?
think yeah, you're absolutely right. I think you can actually see it more clearly on this one, the Ashman phenomenon here and here. But yeah, I think that the point of, as Professor Junaid said, in the first ECG, I don't think it was actually diagnostic. I think more monitoring is required, more ECGs, whether it's a rhythm strip, or even potentially giving the patient adenosine, particularly if they got a high ventricular rate. That can often give you more certainty with the diagnosis. But I think they gave a beta blocker, and you can see with beta blocker and digoxin, certainly. The last thing I would mention with atrial fibrillation is actually, we see this a lot in the cath lab, that if you just sit and watch a patient with atrial fibrillation, their rhythm varies within atrial fibrillation. They can get periods of very organized activity, which when you look at it makes you think it's a flutter. And then it will then become irregular again. So even with atrial fibrillation, although it's characterized by an irregular pulse and irregular atrial activity, they do sometimes have periods of regular atrial rhythm. And also, the other day we had a case of a patient who had 3 different rhythms within their left atrium. The left atrial appendage had an organized rhythm, the rest of the atrium had a disorganized activity, and pulmonary vein also had activity. So depending where the leads are, sometimes you can see more regularity. So look at the whole ECG as a whole and recognize that even with atrial fibrillation, the rhythm can sometimes fluctuate.
Okay, we'll go to the next slides. So this is the transthoracic echocardiogram following the control of her heart rate. Anyone would like to comment on this echocardiogram? Professor Junaid, do you have any?
Really, with limitations of two images side by side on a small screen,
Yeah.
the discordant action is very clear. The ventricular size from what I understand remains normal. So the panel on the left, as we see it, is a axis parasternal view with the right atrium, right ventricle, left ventricle, and left atrium being seen as part of the aortic root and the aortic valve. I think the valve, given the limitations of atrial fibrillation and the rate itself, I think the valve seems to be all right from what I can see. On the right-hand side, there is the short axis parasternal view, which shows the ventricular contraction in a discordant manner. I'm not confident that I can formally exclude any regional wall motion abnormality, but it doesn't look too bad, and I think the overall function seems to be pretty decent. I would like to see the measurements to understand whether there is some left ventricular hypertrophy there or not, because she is known to have hypertension, and the calibration here isn't as obvious for me to make a comment on that. There's a little bit of an echo-free space behind the left ventricle on the panel on the right hand side. Whether that is just adipose tissue or a little bit of pericardic fluid, I do not know, and I can't comment. And that's as much. I'm not sure. I'm tempted to say that the left atrium appears to be larger in proportion. If you look at the ventricle, left ventricle and left atrium to each other, I think the left atrium is enlarged.
Right. Okay, I agree with you, Professor Junaid. And Ahmad, would you like to add anything from this?
Well, I think that was a very comprehensive assessment, really. And I think, as we mentioned before, that with the COVID guidelines for echocardiography, we're going to get limited scans, and these are the sort of real life images that we may have to sort of face and interpret. The only thing is from the recommendations from the British Society of Echocardiography in a COVID patient, or this patient is not COVID, but in a COVID patient is not to do the ECG.
Yeah, I agree. Usually there is no ECG, but for this patient, unusually that they put an ECG. So,
sorry, can I just jump in again?
Yeah.
One or two points. Yes, the guidelines I accept are in terms of protecting the staff and the team from being exposed to suspected COVID patients and so on and so forth. But I think purely from a delivery of care point of view, and with my interest in cardiology and arrhythmias and stuff like that, I'm very, very keen that we should look for, particularly in patients who are presenting with an arrhythmia, you should have ECGs, you should have proper timing, you should have echocardiography, because this is vital information that tells you what the outcome of a particular patient may well turn out to be in the fullness of time. And you know, if you don't have that information to start off with, you can't do a prognostication, and you can't do management plans as well as you would like to.
So this is the report of the, thank you very much, Professor Junaid and Ahmed. So this is the report of the transthoracic echocardiogram. As we all agreed that the function, the LV function with normal, there was a severe LA dilatation, a mild aortic stenosis with trivial AR, and there is mild to moderate mitral regurgitation, mild TR. There was no comment on the thickness of the LV or hypertrophy, but I think she has mild LV hypertrophy. So on day 4, this patient was ready to get discharged. She felt much better. Her AF was well controlled. Her breathlessness was improved. Her leg edema subsided, and she was in AF when she was discharged with a ventricular rate of 75 beats per minute. Her weight was 58. She lost about 1 kg. Her kidney function were reasonable. And these are the medications she was discharged on, the heart rate control medication, furosemide, and of course anticoagulation, and the antihypertensive, her usual antihypertensive medication. So the diagnosis, or the discharge diagnosis, was new atrial fibrillation and HFpEF. So this was heart failure with preserved ejection fraction, and probably the atrial fibrillation, the hypertension. Those are the usually the risks for this type of heart failure, as we all know. And the decision was not to follow her up in a cardiology clinic as a routine follow-up, and just the GP to continue follow this patient for her current condition, whether AF or the adjustment of furosemide with regard to heart failure. With that, I come to the end of this case, and maybe this is just some kind of points for discussion. We thought about the overlap between COVID-19 heart failure symptoms. Obviously, this patient did not have much chest symptoms other than the breathlessness, but she didn't have any cough as such. You know, obviously, the rate control strategy was the strategy that was offered for this patient, and she was treated with diuretics, and her treatment, actually, she responded very well, and she didn't need to stay for long in the hospital. And as we all know, the stroke prevention is always part of the management of atrial fibrillation. And transthoracic echo, of course, to guide the treatment and to classify the patient whether they are HFpEF or HFrEF. And you know, this patient had initially a raised CRP, and procalcitonin was guidance whether she needs an antibiotics or not. So she did not need, actually, this patient, an antibiotic. There was no, other than raised CRP, there was no obvious source of infection. That's it for me. Any comments or questions? of
I
the
think
panel.
Professor Demejo had a comment.
I most certainly do. Emma, do you want to say anything about the rhythm management first, and I can then start making my.
Yeah, I mean, I think it's very reasonable in this particular case to go for a rate control strategy. To rate control, for me, every patient should have rate control, and then a reassessment of their symptoms, and the fact that she had heart failure with preserved ejection fraction, for me, I think rate control is a very reasonable strategy.
Okay. Right, thank you. I have a slightly, ever so slightly different opinion, in the sense that you've got a 94-year-old whose CHA2DS2-VASc is 4, given her age, gender, and hypertension. She is presented with clinical heart failure, and if you push your luck and your calculation a little bit, you kind of think, okay, if it is heart failure, add in another one. So she got CHA2DS2-VASc of 5. That gives her a stroke risk of very easily between 6 and 10% per year going forwards. Yes, she's at the top end of her life spectrum, and I respect that and understand that. But something has triggered her decompensation. Her decompensation is due to atrial fibrillation. Now, rate controlling is fine. I suspect you will lose because of her age, her physiological capacity is attenuated. She then loses 25% of her cardiac output as a consequence of going into atrial fibrillation from sinus rhythm, and therefore she is symptomatic and presents with congestive heart failure. We've given her symptomatic treatment, and we've then put her in a position to live without the 25% being restored. So in my books, I would have probably attempted to see if I could get her back into sinus rhythm if I possibly can. Not necessarily with cardioversion and stuff, but I would certainly have attempted to give her something like amiodarone, or maybe even IV beta blocker up front once the heart failure was controlled a little bit, to see if I could restore sinus rhythm. The negative on that side would be that if she's got significant atrial dilatation, then the likelihood of recurrence is greater, and therefore she will flip back anyway. And we've all grown up with this adage of atrial fibrillation begets atrial fibrillation. So once there is AF, it'll always aim to come back anyway. But with hopefully, if we notice the difference between medication, when she came in with ACE inhibitor and no rate rhythm control medication. She's gone out with DIG and beta blocker. I must admit that I'm not a great fan of digoxin unless my beta blocker strategy has failed. And I would add in DIG only purely for rate control, because it doesn't do much for ambulant rate controls. It only controls rates at rest. The one point that I would like to make is that I think she went out on lercanidipine. I must admit, I mean, the data around the angiotensin receptor blockers in their role for remodeling atria and for reducing AF recurrence is such that I would probably have gone for swapping the lercanidipine for an ARB of some description, and probably sent her on a higher dose of beta blocker and ARB along with the apixaban if I was going to accept atrial fibrillation as the predominant rhythm. But in my unit, I would have probably chased to try and put her back into sinus rhythm if I could, because at her age and her physiology, the primary aim is to give her a good quality of life, not longevity of life. And therefore, if her quality of life is better because she's got an additional 25% of her cardiac output or normal cardiac output back, then that is what I would aim for. Thank you.
And
Thank you very much.
Dr. Demejo. And Dr.